Hello, everyone, and thank you for joining us for this Bay Area Botox Roundtable. My name is Summer, and I am a business development manager here in San Francisco. We have a great program planned for you this morning with Dr. Moss, and I'd like to go over a few housekeeping items first. This program will be running from 9 a.m. to 11, and we have a live injection in between. All participants are highly encouraged to join us starting now via camera. So please feel free to click the camera icon and also know that you will only be able to join via camera if you are on a laptop. Also, please unmute, participate. There are also chat box functions. So in the chat box, you are welcome to ask questions. Please let me know if there's anything you'd like to discuss. I believe the chat box function is anonymous and the questions everyone can see. Is that correct, Jean?
It's the other way around, sorry.
Okay. So the questions are anonymous. If you want to ask any questions that you would like to know but not have your name shown, and the chat box function, we will be able to see your name. And if anyone wants to also just say a quick hi in the chat box function and make sure it's working, please do so. And if you can't come on camera, great. It is Saturday. Messy buns and glasses and kids and pets in the background is all welcome here this morning. So I'd like to introduce our speaker, Dr. Corey Maas. Dr. Maas is a board-certified facial plastic surgeon and owner of the Maas Clinic San Francisco, the Maas Clinic Truckee, the Appearance Care Center, and San Francisco Rejuvenation Center for Clinical Research. He is a member of the American Academy of Facial Plastic and Reconstructive Surgery, chair of the California Society of Facial Plastic Surgery, California Society of Otolaryngology, Head and Neck Surgery, San Francisco Medical Society, and California Medical Association. Dr. Maas was an investigator in the Juvederm Voluma XP pivotal trial and has conducted many other clinical trials. He is a highly regarded thought leader in San Francisco and nationally for his numerous publications, lectures, and studies. Welcome, Dr. Maas.
Thank you. That was a very nice introduction. Hope I can live up to the expectations. So are we going to get started with the, you're going to talk a little bit, aren't you, first, Summer, about the
program?
Yeah.
Nope, it's all yours. So we're going to go ahead and start with the slide. Jean will be forwarding the slide. So go ahead and let her know when you want to go to next slide.
Yeah, let's move. So I thought let's move to the next slide. And there's, from what I can see, a lot of experienced users that are participating today. And I certainly welcome any questions that anybody has. So we're in advanced use, and I think that's, the more we share information, the better. You're gonna do these questions. You want me to? There's some fun. There's some fun stuff.
Right. Okay, so we're gonna start with a little pop quiz. See if anyone knows this, and please feel free to unmute and say it, or put in the text box chat. When was Botox Cosmetic first approved by the US FDA? Anyone know? Do you know, Dr. Maas?
I do.
All right.
Do I get to write it in anywhere? Do I?
Nobody's yet. It's Saturday. Everyone's having their coffee. So 2002.
Yeah, okay. I thought there was going to be multiple choices, but. Well, 2002 was the year that that really was a pivotal year, because for those of us that started using Botox early, 91 was my first injection. 92, we started really doing some work with it, and including research. And I was in Europe speaking about it at an international meeting at MCAS, which probably some people have heard of. And the room was fairly empty at that point. And I had Ben Asher, who ran the program at the time, I think he's still involved, said, with this nice French accent, we in France, we don't do not crowded, and it really wasn't. It's a 500-person room. There was probably 50 people there, and I came back, and so that's really the way it was. And things were slowly being adopted here by a group of people. California was a big leader in this, West Coast in general, with Gene and Alistair, but by the a decade later, 2002, and probably I was there 2005, it was standing room only in that same exhibit hall in Europe. So that FDA approval made an enormous difference, for whatever reason, in sort of getting the trend for Botox to where it is now, and where most people know it's, I think, the third $1 billion drug that hit the market after Prozac and Viagra, I think, were the first two that hit the billion mark. So, which is interesting. So we're going to talk about the benefits and try to get to the live demos quickly. And again, I think a big focus, at least for me as a surgeon, will be talking about anatomy, because a lot of the diagrams that you see in the PI, the package inserts for these drugs, haven't been updated, and should have been. Next, we'll have the next slide. This is going to be a non-label discussion, but it doesn't mean people can't ask questions, so don't worry about that. And there is this sort of boxed warning about distance spread that got added on later. I won't even get into this, but distance spread and the doses we're using is incredibly low. And what we're really talking about for the most part, which we'll get to, is avoidance of eyelid ptosis. That's really the quote-unquote distance spread. We're not seeing a lot of these things on the list that, like the neurologist who used 1,500 units of Botox for muscle spasticity in the body. See, just the doses are so low that we're doing. And when I say doses low, on average, the recommendation, as we'll get to it, is in the mid-60s range. Many people get, to 100 units or even more, but for facial cervical applications in aesthetics, and that's all good. But that's not the, that's beyond label is what we'll stay with. Next slide, please. Okay, the why, that's a good question. I'll take the next slide. So,
Yep.
Let me, before you go, I'll let you go ahead and ask this question. I'm sorry, go ahead, Summer.
So how many vials, another question to engage the audience, how many vials of Botox cosmetic have been distributed globally since they were first approved? I'll give the answer, 100 million.
So we don't have multiple choice, but I think that, next slide.
Yeah.
I think the important part about why is the 30 years of experience, and for those who haven't had a chance, whether you're most of the people on this call are more advanced injectors, if you get a chance to visit Freeport, where the manufacturing facility is, it's a very, very cool place, and it's remarkable what they do in terms of making sure that what's in each bottle is 100 units, and we'll talk a little bit more about this later, but there's different ways of testing that. Most of them are use animal models. In fact, all the companies except Allergan have only animal models. And of course, the reasons that we use units of measure are because the weight of the product in the bottle is so tiny. You see something of a film at the bottom of a Botox bottle, and the weight of that would be measured in nanograms, which is just so tiny. It's like 1.92 nanograms on average, but that you couldn't tell that bottle to bottle. There's no way to measure the consistency of that. That's why the unit of what's called specific bioactivity is employed. And getting used making sure that the number of units that are in each bottle is really the key thing for all the botulinum toxins that are commercially available. And I think the tightest spec, while they do give some wiggle room, the FDA that is held by Botox. So they have the ability to obviously make an awful lot of these bottles that go worldwide. And you can see it when you're on the tour where they have it labeled for, literally every continent, maybe not Antarctica, but every other continent on the earth. So 98 out of the 194 countries there are in the world, which is impressive. I'll have the next slide. And the applications and uses just keep increasing. So from that early period that I was describing in the 90s when I started doing it, and I have got tapes of me talking about it in 92 at this meeting in Newport, and it's a chance for me to plug our meeting in Newport Beach that's going to be first part, end of July, 1st of August this year. And this is where I think the launch really started going, and I think 1994 was the first year. And I just remember, because we knew so little about it, talking about how we should avoid the lateral canthal line area because of the possibility of people having lag up thalamus, the inability to close your eye, which in retrospect is very funny because it's probably the best indication for the use of botulinum toxin or Botox, and that is because it gives brow elevation and helps with the hyperkinetic facial lines. And then I think it was a big advance that many don't know about, but there's an in vitro assay they have to assure the consistency in the bottle. Most people use what's called LD50, and that's what units are. The LD50 is a biometric measure of potency, and 1 unit is the amount of intraperitoneal injection in a approved rat model that would kill half of those dosed. So that's just so you know that. I mean, it's done with animals in general by all the other companies, and Allergan has this in vitro model, but they are lab rats, so we're not talking about big animals. And then when we got to, by the time the genie was out of the bottle, long before Botox got approved. And so we were talking about it widely and doing it widely in the early 90s, and new ideas and applications were coming out every day. But the only company that's actually sought and received approval for the 3 areas of the upper face is Allergan, which is helpful for us because we can, and them, because we can openly talk about it. And that's a big deal because I think one of the, and I'm sure those on the call that know about this, that one of the reasons people are reticent or is to trying it is because they really don't know very much about it, and the commercial marketing that they do is very tasteful, and it gets the name out. So Botox is now a brand name, and it sort of represents the entire industry, if you will. I would even go so far as to say the whole plastic surgery industry. I mean, it even kind of includes things like facelift in some ways now. Love the next slide. So that's a brief history. I guess I should add that Alan Scott, who is a retired ophthalmologist who did a lot of work with kids and strabismus, which are eyes that don't have conjugate gaze, is really the guy. No one invented botulinum toxin. It's been made in nature by Clostridium, but he was the one that used a cell culture line from the University of Wisconsin and started working with it in kids under an IRB and looking at it to treat strabismus or cross-eyedness, and rather than having surgery, which is a big deal. And a lot of those were kids that had severe neurofunctional disorders. And his observations led to ultimately doing it for blepharospasm, which is the twitching of the eyelid. And the observations from that were that the lines got better, and one of his fellows was Gene Carruthers, Brothers, which was in the late 80s, early 90s, and her husband really were, most people have at least heard of them, were instrumental in getting it started, and really started speaking about it at the meeting that I was talking about in Newport. So we, amongst many other places, but it's been around since that. There's a long and great history for it. The three areas that are approved, of course, the first one was the glabellar, in between the eyebrows, and we're using these little icons. You can see the forehead, glabellar lines, lateral canthal lines, are on-label indications, which we'll talk about primarily today, and we'll have the next slide, please. But it's the only one of them that has that's approved in those three areas. So precision is about having the right number of units in the bottle, and so you know that no matter what volume of diluent you use to reconstitute it, it comes as a lyophilized powder. It's in the bottle, but you know that you get 100 units in there. And early on there were, and there still are, ranges of people with volume of diluent that are being used, with the peaks being around, or if you look at this as a bell curve, around 2 cc's to 2.5 is the average, but there are people who go with the very, very low volume at 1, and the highest it's on average, again on a bell curve, is about 4 ml of diluent in the bottle that are placed. Next slide, please. So I think I'll do this summer, because we just did the approved dosage for simultaneous treatments are the forehead, the glabella, or in between the eyebrows, and the lateral canthal lines, or bicularis oculi. And I think I got that answer correct, didn't I? Yes, okay, next slide.
Yeah, and the approved dosage.
That's right, and the approved dosage. And that's what we're getting to. So, when these things started, I mean, Alan Scott will be the first one to tell you had a very funny experience with starting these things. And sorry for my lighting, I'm going to fix that. Because obviously there were no norms when he started. There were no data published, and even the amount of that was in the bottles or syringes even that he was using at the time were unknown. So he had a monumentous task of trying to figure out what the best doses were, and I think we're still working on that, and there's still a lot of art to this. So when we're talking about these today, I will just say that these are good numbers that represent those that were studied and controlled clinical trials, and still there's an art to this that for those, a bunch of experienced people on the call, on the conference today are really very, I'm sure, acutely aware of. I would say, as it relates to these three areas, that the glabellar lines at 20 units on average works very well, and gives consistently somewhere in the neighborhood of 3 or 4 months of duration for people. And lateral canthal lines, 12 units, and you can go, obviously on label, that's the right number, but there are many reports of going much higher. There are many reports of going in smaller numbers than the 12, but in general, that's going to give you an early good result, and the duration of effect will be less if you use smaller numbers of units. So you want consistency for your patients, and not just the smoothing of the lines and the hyperfunctional frown activity or muscle activity, but also the consistency and duration of effect, which speaks to the unit dosing that were used. And so in simultaneous improvement, this is the on-label, studied, and approved dosing that are out there, so that you have those, and the data are there, and that's what the FDA says, and you'll always be in good shape if you're using in this range of dosing. But remember, it's an art, so that's the key. You want to Yeah, we'll talk about this more. You want to assess the patient and make sure that your dosing is consistent with the needs of that particular patient. Doesn't mean every single patient's going to get 64 units. Next slide, please. So I would say that one of our, if we look at the big picture here, there are now, the data suggests that more than half of injections are not done by doctors, but by nurses. And so in particular, if you're a doctor that are supervising nurses doing these injections, you want to share your understanding of anatomy with them. And diagrams like these in many of the publications. There's a study we published in 2002, which was a cadaver study looking at 100 hemi heads, because you have the anatomy on both sides of men and women, that the cadavers, male and female cadavers, and looking at the relationship between these muscles. But the understanding is really critical. The frontalis is a very powerful muscle that elevates the brow, and while it makes lines that are the horizontal lines that people often complain about, it also is the main muscle that keeps the brow up. And so one of the ways we can avoid having brow ptosis or drooping of the brow is to reduce the amount of the brow depressor function by treating the lateral canthal lines, or the orbicularis oculi, on this lateral outside part of the eye, is demonstrated here, and the corrugator supercilii muscle, which pulls the brows together, but also in most people pull the brow down. So there's this yin and yang thing with the frontalis muscle and the corrugator superciliary orbicularis that you're treating. And this is why I was saying individual dosing is for each patient is so important. Next slide.
Mm-hmm. I love that yin and yang. I use that now from you, Dr. Maas, when I'm training on Botox.
Yes. Oh, good. Because I think it's really important. Really important. I think it allows, if we treat someone that has brow hooding, and the person on the left might be a good example of this. You can see a younger person who has relatively smooth forehead skin, but sort of heavy lids. Doesn't mean you're necessarily old to have heavy lids. And if you treat those, if you over-treat the forehead and don't release the brow depressors by doing one of the two that are shown here, typically I'm more in the first of the two, in the central column of treating lateral canthal lines, and treating the corrugator muscle. And the only thing I'd add to this, and I'll tell you another story, but let me finish that thought. By doing more relaxation of the depressor function, which happens by treating the two indications in the middle and on the right of your screen, the lateral canthal lines and the corrugator supercilii complex or glabellar lines, it allows you to do a little bit at all, but a little bit more in the forehead lines, remembering that the frontalis is the only elevator of eyebrows. And I've said this many times to my patients, that brow function trumps lines. So you'd rather have good brow, good brow position and a nice open eye look than you would have no lines on your forehead. So that's the balancing act that treating the frontalis or treating the forehead in general, you always have to manage. It doesn't mean they need a whole lot of movement, but they have to have at least muscle tone in the frontalis when you're finished, or you'll have some brow drooping. And the other thing I point out in this model, which is really important that you do, and I would also suggest, while I'm throwing a lot of things out there, that you use clinical photography as much as you can on your patients. With iPads and iPhones now, you can have really good documentation. This patient, the left brow, has a little bit of, she's an untreated patient, let's assume, and her left eyebrow arches and peaks a little bit more. And if you don't point that out to the patient before treatment, they'll come back and tell you that their right brow used to peak and arch just like that, and now the treatment has created something that wasn't really their natural baseline. So using clinical photography, and especially when you're doing the assessment, hand in the and the mirror in the hand of the patient you're treating are critical things. And then the last comment I would make about this slide, which I think is really important, like I said, is Allergan is the only company that's gone back and lowered the dots on the picture diagram on your right, the package insert. And that study that I described to you that we published in 2002, the work was all done in the 90s with that cadaver study, but it was finally published in 2002. The corrugator muscle descends with the eyebrows. And so as we age, our brows get lower, and the muscle itself is where we want to treat, and it doesn't, there's a lot of anatomic diagrams, but in practice, on almost all patients, the corrugator follows the sort of shape, if you will, of the brow, and you can feel it between your fingers. And so you really want to stay in the corrugator muscle. If you go too high, you'll get a lot of medial frontalis, and that's how we get that sort of Spock look or the Mephisto look. There's all kinds of descriptions, but where the medial brow goes down and the lateral brow goes up too high because we've over-treated the medial frontalis muscle. Next slide.
Mhm.
Well, we'll talk about this more when we get to live demos. And so this is, again, an accurate representation. It also shows some of the other facial musculature that is on there. And you can't probably see my pen moving around, but the Nasalis is the muscle that crosses over the surface of the nose. And
I think we can see.
okay,
We can see your mouth, I think.
I don't. Can you see? I'm waving
No,
it
wait.
around. Yeah.
No,
So.
you're not.
Yeah, so the Nasalis muscle is the one that is going over this isn't perfectly anatomically correct, but that muscle creates the so-called bunny lines. The muscle that's just lateral to that is the levator alaquinase muscle, and then the zygomaticus major and minor muscles are your smile muscles. But the main ones we're targeting are the purple one there that you see is the frontalis. And the frontalis usually ends, the muscle itself, if you go from medial to lateral, about a centimeter before the line that it creates, the horizontal line ends. So just so you know, if you're way out at the end of a line, you're probably not hitting the target. So you're staying just a centimeter or so medial to where the end of the line is. A lot of people treat, these are not aesthetic indications, but temporalis muscle that you see there, or the masseter muscle, which you can see below for bruxism and other type TMJ type syndromes, which are on-label uses, but not for our discussion today. So that's the forehead line, and we'll go to the next slide. I would just say, as we go to the next slide, how you treat the forehead is going to be really the area that is the most variable. And in some patients that have really heavy lids, dermatochalasis, which is the excessive skin on the eyelids, low eyebrows, those are people who are not super great candidates for treating the frontalis muscle. So always be cognizant that you don't have to stay in a specific pattern of 64 units, and you have to use your own judgment to determine whether treating the frontalis at all is worth doing. But if you are treating it, I strongly recommend that you do doses that are small and that are widely distributed across the forehead, and this sort of M pattern that you see here with the purple dots is a way of doing it so that you know you have symmetry. Some people actually put the dots down with some type of a marking pen or crayon, a wax crayon or whatever first to assure symmetry. I think when you get enough experience, you can probably eyeball it and get good symmetry. But I'd also caution you that if you're using a lot in the frontalis and you're doing it near the middle portion, don't forget about lines near the hairline, because you don't want to have a smooth brow and lines by the forehead hairline. The hairline that's sort of the giveaway lines, I like to call them, where someone's making
Right.
expressions and you see only lines up near the, very top of their brow. So that's an area where you want to be in particular sensitive to if they have lines up by the frontal hairline. So you can distribute this widely.
I was just going to say really quickly, I know we'll be going over this in live injection, but please, just to encourage anyone, this, from what I found, is one of the most, the area that brings up the most conversation and has the most questions. So please feel free to ask questions, or if there's a case you've had that you wanted some guidance on, this is definitely your opportunity. So just wanted to put that out there. Sorry to interrupt, but you're welcome to chime in at any time. There's no need to wait for a question and answer section.
That's a good point.
Go ahead, Dr. Maas.
That's a good point. So I would encourage anyone that has, and beg anyone actually who has comments that, or ideas or little nuanced ways that they feel they get better outcomes to share it with us, because that's what these meetings are all about, for all of us to learn from each other. And while Allergan is great in providing this educational opportunity for all of us, it's really the sharing of knowledge between each other that gets us the best outcomes for our patients. So if you're willing to...
And you can also just unmute if you want to just do conversational too. No need to do type it in also.
Yes, that's a good point too, because I'm not looking, I guess I should be looking at the...
I'll monitor.
Okay, you're gonna monitor the chat function.
Yeah.
The chat function is, if you don't feel like talking, the chat function's on the right side of the control panel down at the bottom, and you can click on it. You can even send private messages if you want. So, so look, I would just add to this that the patterns for doing this vary, I would say, very widely amongst injectors. Doing 20 units is the top end of where I go with Frontalis, and when doing those types of dosing units, I am really distributing it very, very widely with tiny symmetric, this is the key, tiny symmetric little dots, little drops, if you will, of Botox, and trying to, the key is even distribution of where the dots are and even distribution of dosing. And that way you won't have asymmetries or people coming back to, to get a touch-up or retreatment. I'll also say that for the new patient, if there's any brow ptosis or any eyelid skin hooding, dermatochalasis, it is better to introduce them slowly and probably do the lateral canthal lines and glabella first, get them, get the trust they have in you and in the product, and then introduce later the frontalis. A lot of people come in with frontalis lines and that's their only complaint, and you've got to explain that to them, and then just start with really small dosing and go up, because they'll get a sense of it once you've treated them. And once you explain to them that the frontalis is the only muscle that lifts the brow, and while we don't like the lines, we don't want to trade off good brow position and a natural appearance. I think those two things, for at least for where we live, it's maybe a little different in SoCal, but for where we live, people typically want to look natural. So this is the one area where the greatest risk of losing that natural effect is. And if I welcome any comments. If anybody has any thoughts or experience with that, just speak freely. Okay, the next slide.
I have one question. It says, are you able to talk about injecting a CPL unit under the lateral brow for lift? Do you feel that injection can help lift the brow up? If so, can you talk about unit and placement? Thanks.
That's a lot. Say that. Give me the question. I'm not seeing that question, so
I'll do the first one. Yeah. So are you able to talk about injecting and a couple? Okay, so CPL, I think that's a couple units under the lateral brow for lift.
Yeah, that's a good. That is a good question, and I think it's out there, and it's been in many, not just many talks that I've seen. It's also been, um, sort of widely discussed as a given that doing a few units in the lateral brow or in the orbicularis, since we're now talking about brow lifting, and a lot of people have patients that come in with the misconception or misunderstanding that treating above the eyebrows lifts them. I've had so many people come in and say, my doctor usually treats above my, XYZ areas to lift my brow. And you have to start from the beginning and say, look, Botox relaxes the muscle. So if you're treating above the brow, you're not lifting, you're actually smoothing the lines, but you're not lifting anything because you're relaxing the muscle that lifts. The other part is where you see, 2 or 3 units being used at the tail of the brow. The only thing I can say is that we published the original paper on brow lifting, which is in the White Journal, Plastic and Reconstructive Surgery, where we did a controlled trial looking at a series of patients treating the lateral orbicularis oculi and then measuring fixed points, the distance from the mid-pupillary line to the lowest brow hair, and they weren't allowed to pluck or tweeze their eyebrows or wax. And then from the lateral canthus to the lowest brow hair. And we showed in that study that was published in the early 2000s that on average, and this just happened to skew toward younger patients because people heard we were doing a study on, lateral canthal lines and you could get free treatment, but it happened to skew because a bunch of friends told each other toward a younger population. So the average patient in that study was probably in their 50s, early 50s, which I consider very young. And in the study we showed 5 millimeters of brow elevation, but that was where we really eliminated the entire lateral canthal line or lateral orbicularis area, the portion of the muscle where the brow is being pulled down. And there are no studies to my knowledge that I've followed this to show that doing 2 or 3 or 4 units at the tail of the brow lifts. And I'm not saying that it doesn't, I'm just saying that there's not enough data out there to prove that it does or that it does so consistently. So that would be a great study, and it probably helps a little bit. It certainly doesn't hurt to lift the brow, but at least in our study we used I think 10 units, but 12 is even better. And if you maximize the reduction of the depressor function in the lateral canthal area, the orbicularis oculi muscle, that gets you the best chance to lift the brow. So I'll say that, and then the nuances of a few units here and there, I don't know enough about it, but I've seen good pictures. They're just hard to assess because you don't really know how much the patient's raising their brows in the before and after pictures. And this has always been a problem with, even with brow lift studies and treatments for brow lifting are always skewed by how much effort the patient is making to lift their brows. Anyway, that's a long answer, but a good question. Unmute.
Yep. I think that covered the rest of the question. The rest was if you feel that can help. Do you feel that can help with the lift brow? And also, if so, can you talk about units and placement?
Yeah, so I think the best way, so it doesn't mean you can't do it, and especially if somebody's on a budget, they may say they may not want to do 12 units on each side and 10 in between and the whole thing. But if they're, first of all, if they're on a budget and you're going with small numbers of units, I would say if you want to get brow lifting, skip the forehead and use the units in the lateral canthal lines. If they're doing the full treatment and you want to get the brow up as much as you can, then do a smaller dose but even distribution in the frontalis muscle, and maximize the dose in the lateral canthal region or of the orbicularis, and definitely do in between. I mean, you can look in the mirror yourselves and see how much, there are a number of, and I'll refer you to a couple of my publications on this. There's tremendous brow depressor function of the medial brow, and Andy Frankel in LA wrote a nice paper on medial brow elevation with botulinum toxin, and then the lateral portion we wrote. And if you combine those, you'll get really nice brow elevation. But the smaller the number of units, number one, the less the brow elevation, and then number two, the shorter time that it will last. I just keep those things in mind. If you're not on with on-label dosing, it's going to last a shorter period of time. Very good questions, though. So
yes, I actually have another one.
okay, is there another?
Yeah.
One? Yeah, I'm ready.
Okay. So patients have been asking for ponytail lift, referring to injection into frontal scalp from a centimeter beyond hairline to inhibit forehead depressor and lift forehead. This would theoretically also allow more thorough treatment of frontalis without as much risk of heaviness. Any experience with this?
Well, I think this comes. Well, the history of this is that there's been a long tradition of doing a brow lift by pulling your hair back in a very tight bun or in a very tight ponytail, and that's not new. And but it does work. And it's also true that the frontalis muscle does, as you can see in this diagram, through the connective tissue layer, the Galea aponeurosis, connect to the occipitalis in the back of the head. And in practice, if you think about muscle function, it's interesting. The frontalis really is sort of pulling from the frontal hairline. It's actually pulling down, and from the brows, it's pulling up. It's shortening the distance between the two. But it really, the downward function, if you will, the shortening of the muscle at the hairline is much less significant than that of the lifting of the brows. Over evolution, obviously, we get heavier lids, and so if the frontalis wasn't functioning to lift the brows up, we would have, as we age, we'd have more and more visual obstruction, I think. So that's a long answer to, and I'll say the short answer is that no, I don't have experience with this. Those are areas where more studies need to be conducted, and I see that Tam Foster's probably asking that question. Tam, I don't know if that's the kind of stuff. Those advanced Botox injectors that have tricks should speak up about that. But I really think that these are areas that need more study, and I do not have personal experience with treating that area and seeing brow elevation. But I'm open to anybody who ever asked the question could probably share what their experience is.
I think that was great. Thank you.
Okay, so
no further questions at the moment, but thank you everyone for asking. Keep them coming.
yes, keep them coming. So this is the area, again, it's a very powerful depressor of the brow. So if we really want maximum brow elevation, you have to include treating the lateral canthal lines, and if you do the hours of a clock, it would be from somewhere around 7 o'clock, so on the two eyes it's going to be different, but on the right eye it's going to be from sort of 7 to 11 in that area, everybody being a little different. And on the left eye, it's going to be somewhere between, say 1 or 2 o'clock down to about 5 o'clock, where we'll treat them. To thinking of the orbit like a clock, the hand of a clock. And so, depending on how deep the lines are, you can vary where you're adding the dosing. I would just caution you that, because so many people ask about crepiness under the eye, and crepiness under the eye is not going to be effectively treated with Botox, because that is more about dermatochalasis, and it is more of a function of doing some type of peel or laser or something that tightens skin than it is about hyperfunctional muscle activity. Not to say that it won't help overall, because I think it does if you reduce the squint. There have been a couple papers about sort of opening the eye by treating in the infrapupillary region, but I would just say that in my experience that it doesn't really do that much, and it's probably not that helpful aesthetically. Most of the time we're trying to keep the lower lid up as we age. It sort of sinks down. That's called lid retraction. So, but for this area when you can get your patients to do it, even in the younger patients, I say if you really want to have the best shape to your eyes and keep the eyes open and low, you should really be treating the lateral canthal lines and the orbicularis muscle. Now, included in this diagram, interestingly, is the levator palpebrae superioris, which is deep to the orbicularis oculi. It's deep to everything, and this is the muscle that you can see in the top right, that when treated, that when molecules get there incidentally of Botox, will relax the eyelid and cause eyelid drooping. And so this is something that has been very commonly discussed. And I will just tell you that the concept that this is purely migration is really an anathema. It's really highly unlikely, given that that ophthalmologists very frequently inject the eyelid directly to treat blepharospasm and don't see eyelid ptosis by relaxing that muscle. You can see the arrow there, and then we are blaming, when we see this, it's almost always from treating the corrugator muscle in between the brows. And it's much more likely that it's a few molecules that are tracking along the superior orbital fissure or the supraorbital or supratrochlear foramina. Those two little holes that are in the skull that aren't depicted here, but are not far from where the arrow are where the artery and nerve come out. And if you just get unlucky, it's really a luck thing. If you just get unlucky and a few molecules track right back along those, and everybody can have either a notch here or they can have a hole or foramen. And so those, if you can feel yourself. We've found that the people with the notch sort of phenotype have a greater chance, but it's just a lower plunger pressure and injection is the key thing, and I'll show you. But lifting the corrugator away from the bone when you're injecting, and not going straight at the muscle itself, but rather coming more from the side medially, I think helps to avoid those, which should be tiny numbers now, because they were 3% in the original study, and they're much lower than that now. Next slide. I'll try to get through this because we're running short on time. And so you'll see a lot of different patterns of injection. I like the idea of treating where the pathology is or where the condition is, and you can see from this picture that on the left that this person has a very active wide distribution, and that in the picture on the right it's more limited. But keep in mind that the orbicularis does surround the entire eye, and it's a sphincter muscle just like your mouth and other sphincters on your body. So you can treat it evenly, and I think that gets you in my experience, gets you the best result. You can't really treat too much here. These dosing units are to me on the small side if you want better duration. Next slide, please. And then describing these in patterns are interesting, primarily because I think you see, well, first of all, pointing these out to patients, because the patient on the top left, the U pattern, is going to have a lot more brow depression and a lot more pulling down of the brow, and would expect to see a lot better improvement in brow position by getting that strong muscle relaxed than the person that's on the top right, the V-shaped pattern that's being described. They are almost purely adduction of the brows, pulling the brows together, whereas the one on the top left is really pulling down and together, if you will. And so every one of these has its own unique sort of physiology or an anatomy, and that just shows you this variation. And I'll also say one that's not included is you'll see people, but they're very few in number, that have primarily a deep horizontal line. The lady in the top left has a deep procerus line, but in some people the procerus and even the corrugator is more vertically oriented, which gives almost a straight down pull to the brow. And while it's a very rare, unusual sort of phenotype, it is out there. So just treat where you need to. Next slide, please. Based on the anatomy that you see and feel. So the procerus goes up and down. It's a major depressor of the brow. But on the other hand, if you don't see a horizontal line at the base of the nose, and you don't see the patient really creating those lines when they're frowning, and you should ask every patient you're treating to do expression, then it's not worth wasting the unit there. You use the unit in the corrugator, not just because the 5 dots are shown. You know, that's where we need to use our own individual skill in assessing the patient. Next slide, please. And everybody's seen these kinds of pictures before, and I would even say, from my perspective, these are a little higher than I would have my dots. But so in general, when you're treating the muscle, the corrugator supercilii, just remember that the brow descends, the muscle descends with the brow, and you can feel it between your fingers. And the tail of the muscle does swing up at the top edge of the brow in most patients. And it's a lot harder when people have waxed and are using pencil, you know, to put paint in a new brow. So you really have to, don't be tricked by the patient that has or is using different ways of shaping. Feel, look, and you'll identify the muscle in your patients and make sure you get the best results. Next slide. Obviously it's the muscle we're treating. Early in this, people used to say go down to the bone and to tap it and then pull back, but that's really painful. So I think in the lateral canthal lines you want to create a wheel that is subcutaneous, and that by virtue of the anatomy of the relationship between the orbicularis oculi muscle and the skin, which they are all very tightly approximated to one another, you'll get most of it in the orbicularis. That way you don't have to be deep to it. In the corrugator muscle, I'll show you in the live treatment, but I lift the brow and I'm going from medial to lateral rather than sort of straight at the patient, you know, with the injection. Although once you do enough, you can get good at any of these techniques. And the frontalis really is the muscle where if you go and meet, it's a thick muscle, and there are several layers to the muscle, which include the the galea aponeurosis, the subcutaneous fat, thicker skin, and so you do need to be a little deeper in the frontalis. I would say the other trick about frontalis is just really looking carefully for where the vessels are, because you can avoid bruises if you can see and identify the veins on the forehead, which in some people are quite numerous, and that's disturbing to patients. Now they expect us to not be able to bruise them at all, which is not realistic, but if we can get away with no bruises, that's great. Next slide, please. So these are pictures, especially the one on the bottom, with that represents best significant eyelid ptosis. And there are a lot of patients that come in with undiagnosed eyelid ptosis. And then the person on the top has prominent eyes, almost proptotic eyes. But the eyelid ptosis can be quite mild, and typically, remember, it's going to be identified by, you'll see more of the eyelid crease, and some people even like, by the way, their eyelid that has the eyelid ptosis, like the patient on the bottom. But on the ipsilateral side, on the side of the ptosis, the brow will typically be higher than the other side, and the patient will have more of a you'll see more of their eyelid shelf. There's more, the brow obviously is hanging down, so you'll see more of the brow in almost all of those patients. And those are two diagnostic factors. The main thing about it is you don't want to go into treating them without identifying that it exists in that patient, because it's invariably going to be owned by you if you didn't identify it and you treat them. So I would tell you to make sure that you're identifying in those patients the eyelid ptosis, pointing it out. And the last thing you'd want to do in an eyelid ptosis patient, even though their brows are asymmetric, is to treat their brow to make it more symmetric, because the lady on the bottom right now is hiking her brow way up to keep her so she can see. I mean, that lid is probably half covered by her pupil. If you treated her with Botox on that side, that lid would probably drop the lower pupil, and then she'd have a hard time. I mean, she really wouldn't be able to see without taping her lid. So I tell you just that because it's very, very common. Eyelid ptosis is more common than most people think, and then it's a side effect, and then we can talk about the side effect now or later, but you know, using iopidine or a 0.25% neosynephrine drops are ways to temporarily elevate the eye by, and I can write this down or somebody can call or whatever, we communicate about it, but 0.25% neosynephrine drops or iopidine drops are pretty much the standard for temporary relief of the side effect of eyelid ptosis, which should be quite rare in your practice. It does get better usually within a couple weeks, and if people do have it, I tell them just use the drops when you're going out or doing things. Don't keep using them, as it's not a treatment that makes it better. It just treats the symptom until recovery is complete. So, and it does dry the eye, so you got to be careful about that. So there's two of them. There's the two parts of this, I'll say, with eyelid ptosis. The one is making sure you've diagnosed it if patients come in with it, and pointing it out to the patient and telling the limitations that are there. It doesn't mean you can't treat people, but you want to be careful with the side of the eyelid ptosis and not treating that brow, because it'll lower the lid even further. And then there's the patient, that the rare patient you'll have that has an eyelid ptosis, and it's worth talking to people. It's in your consent form. It's a rare side effect, but they should know about it, because if you tell them about it in advance, and it's, you know, it's infrequent, but it's significant for people who have it, and it does go away, then they don't get scared and go, because I've heard this story more than once, that people are going to the ED and with a complaint of having a stroke, literally, because their lid is down. So they will know that it was the Botox treatment and not get a full stroke workup when they really don't have. It's really a very temporary and simple and something that will get better and can be minimized by the use of one of those Mueller muscle, the adrenergic stimulators, the iopidine or neosynephrine drops. Any questions about that or comments?
Yeah, I think actually we're gonna break right now because your model is ready and waiting for our live injection. But absolutely, if there are any questions on this segment before we move on, please feel free to ask them or unmute if you want to add, you know, something that's workful for you, or you know, anything you'd like to contribute. Please feel free to. And we are going to. Quiet. You must just be well with knowledge, and everyone's just learning. So it will be a 5-minute break. So, you know, please definitely step away if you need to for a moment. Dr. Maas is going to unmute his, he's going to mute and turn off his camera, and then we'll see him in the exam room.
Okay, I'll see you guys over there.
Okay, great. Thank you.
So let's start with assessment. And I'd say our assessment starts with, but I already know this patient, so I know this patient, but I'm gonna ask a few questions and we'll do the routine like I don't even know who you are. Okay. And so you've had Botox before?
Yes.
Okay. Mm-hmm. And which areas do you usually treat?
Forehead and around like crow's feet eye lines.
Okay, so can you show us a frown there? Okay, yeah, that's good. You can straight ahead, that's good. I can see it. And then raise your brow way up. And so, how about the horizontal lines? Do these bother you?
I haven't done them in a while. Usually I do it every other time, but I
So
do them
You do,
occasionally.
so, yeah, to keep the lines
Mhm.
from, so you don't have ingrained
Mhm.
lines at rest. And the downside, so, and then what about squinting for me? So you've got some pretty good lateral canthal lines too.
Yeah, I have COVID face.
Yeah, nice. Open face, that's right. So pulling down the brow is really the function of these lateral canthal lines. And she's got some numbing cream. People, the use of the numbing cream is variable. Some people use it and others don't. I would say it's a slight advantage. I think it makes people feel better if nothing else. So in terms of making some effort, especially for those patients that have needle phobia, and it does help a little bit. It helps not so much. The injection is not painful. In other words, the botulinum toxin solution is not painful, but the needle stings a little bit. So the smaller the needle you can use, the better. And I'm going to do it again, wash here. So we have, it's okay to leave it off this. So we have patients getting the numbing cream 10 to 15 minutes in advance, and it's actually, the longer it's on, the better it works, but people don't want to wait around for longer than that, typically, for their Botox treatment or Botoxin treatment. And so with this patient, she does have an ingrained line. I'm going to turn you just this way so we can maybe zoom on that and see. And when these kinds of ingrained lines happen, that's from chronic, that's chronic frowning or thinking constantly. That doesn't necessarily mean you're angry. It's a lot of people concentrate and get that line. So I've seen that line completely disappear, this resting vertical line, as well as the horizontal lines. In fact, I have pictures of myself from when I was 35 years old with a Grand Canyon across my forehead. So if you stay with it, you can actually, the skin's constantly remodeling, you can get some of these fine lines improved. But she has very classic sort of features of someone that's 40 something, and
Thank you.
you're welcome. But so raise your brow. And the other part though is, she's got a little, and then relax. She's got a little bit of brow ptosis already. So I think this is why you alternate, right? So because when you treat, you're going to help the lines, but you've got to do it very mildly so we're not dropping her eyebrows. And that really means small dosing, smaller than probably the numbers we represented earlier, but nice even distribution. And I probably wouldn't go in this patient, more than 10 units total in her forehead, and just make sure that it's all evenly distributed, tiny little drops. And then raise once more for me, Jim. And then she's got a few little lines up by her hairline, so we don't want to see those at the end. Have it smooth here and then little lines up in the corners. That would be sort of a giveaway look, and we don't want to give away anything. And then give me a squeeze here. And then she's got a lot of very powerful corrugator function in her lateral part of her brow. And the orbicularis can actually join in and pulling that too.
Mm-hmm.
So if we do this, the main thing is just to keep in mind, we're going to try to hit the bulk of the muscle medially, and then a little drop more superficially out here at the mid-brow, which will not just pick up the tail of the corrugator, but a little bit of the orbicularis oculi muscle. That's also, it has some corrugation function in the end. And then one more squint here. So she really, like you're in the bright sun. Give me a good, so yeah, so you can see that, how powerful that is, pulling down her brow laterally, and that squint. So we'll really be able to open her eye up nicely here, and she's got pretty eyes. So that's a way to get those pretty green eyes working for her. Okay. So that's our assessment. Botox works by relaxing the muscle. I know you know this, but I'm just going to review these features for you. It takes about 3 to 5 days for it to start working. For most patients, the duration of effect is about 3 months, but on average for our patients it's 4. We know that the duration of effect and the dose are correlated, but we don't want to go too high, at least in dosing. So, especially up here, because we don't want to drop your eyebrows.
Mm-hmm.
You know, it'll be a smaller dose there for you. And then for most people, then I tell everybody to come back when they start to see this muscle moving again, this firing. Because that's, by the time you make the phone call, when it starts to move, by the time you make the phone call, you can get an appointment. It won't be all the way back yet, but it will be close. So that's a good way to get this resting line that's in between to go away, is if we never let that come back to full strength where you can make that it's a powerful muscle, so we'll keep that relaxed.
Okay.
The side effects are minimal. The most common ones are obviously a little needle point redness or bruising, which would be quite rare, but it does happen. And I'm sure you avoided aspirin and Advil and Aleve for a week, the non-steroidal anti-inflammatories. I don't really have a problem with people using fish oil and some of the other things. It's just the aspirin products that really make bruising a significant. It doesn't really increase the frequency of bruising, it increases the severity.
Mm-hmm.
So what would be a little dot would now be a bigger, dime size or quarter size bruise. So we want to avoid that. And the one that is the most uncommon, which I've only seen, I probably see it every 4 or 5 years because we do studies here too, but is where the eyelid itself gets droopy. And that happens because there's the muscle that lifts the eyelid is not too far away from this muscle. It's sort of in your orbit, but there's a little notch right here that you can feel on your self, and that notch, there's a little sensory nerve that comes out from the orbit and goes up onto your forehead, and a little vessel. If that tracks down along that, just a few molecules, then that can relax the muscle that lifts. And if you do get that, it goes away in a couple weeks. We have some drops that you can use, but it's not long lasting. It's not permanent, but it's very uncommon. I don't think you're going to get it. I'm just telling you about it so you know. And so we've told all of our smart people that are watching what's going on with that. So otherwise, I'll get to the treating, and we'll get this young lady on her way. So her Saturday. So there's mostly there's all doctors on here on this thing right now. So you want to lay your head back a little bit. You can't. Is that comfortable?
Yeah.
I can.
Second will be, there you go.
Yeah, I can adjust that if you want.
Ponytail.
That's good. I'm going to give you a little squeeze ball. I have these little squeeze lips we like here, and they have branding on them. You can see that. Yeah, so branding. So if they like them, then they take them home. Which I have a case of these because people take these home all the time for whatever reason. And I mean, it's a nice stress ball, so it works. This is neural gating, by the way. If you squeeze something, or there's other ways of doing it. Some people use the little electrical, like vibrator stimulators on the head while they're injecting. Anything to distract the patient or give them more neurosensory input helps to reduce the sense of well, it reduces the processing of the sense of pain, and that's the purpose of doing that. And I think it's like anything that we do like anything we do with needles, prepping the skin is important with an antiseptic of some kind. Alcohol works, especially for short durations. I mean, Hibiclens, you can do anything. Betadine is messy, I don't use that. A lot of people are going to hypochlorous acid. There have been a lot of recent publications about the use of hypochlorous acid in dermatology and plastic surgery, and it is a very effective way of getting antisepsis, so that's a good thing. And we'll start, and I'll just have the camera crews here tell me if I'm in the way. We'll start here in the
Tilt her
middle.
head a little to the right so they can see the right side. They should.
Yes, we'll
Yeah.
do that. That's what we'll do. So I'm gonna have you turn just this way a little bit, and hopefully my hand's out of the way, so what I'm gonna do is grab her brow here, and I'm gonna have you squeeze for me, like frown. Yeah, and so I can feel the muscle there in between, and particularly out here, because she's got, do it again for me. She's got a really strong muscle out here in the lateral portion, almost more than the medial. So we want to get all those, and I'm going to come here from the side, and a little pinch here. And I think the key thing about this is I've got the corrugator muscle in between my fingers, literally, and I'm moving this around slowly. Now I'm using 2 ml volume of diluent, and most of that injection is going to be in the medial brow. And then I'm going to come back here, and if I go with the brow, here's your, hurts a little less, little pinch. And she's got a very powerful segment right here that's strong, but this is really just probably 3/4 of the treatment dosage and 1/4. So if that's 10 units, it would be 7 to 3. 7 units here and 3 there. 3 at the mid-pupillary line. There's stories about mid-pupillary line, all this stuff. I don't know where all those things came from, above and below and all that kind of thing. Doesn't really matter. It's really just getting it in the muscle and staying away from those foramina that we talked about earlier. And if you do get an eyelid ptosis, it's just not lucky. That's, I can only tell you that. It's not. The way to avoid it, for the most part, I'm going to turn you a little bit this way. So again, I'm going to grab, and you can squeeze for me, give me a frown, and relax, so I know that her brow's right in between my thumb and forefinger, and pinch. And you notice I'm not pointing this needle toward those foramina or the sulcus in patients that have that anatomy. And then I'm going to do that second. I'm pulling it away from, pinch, away from the foramina, and doing a second drop there. And her muscle's pretty strong there laterally, so I wouldn't forget that drop. And then you notice I didn't do anything here yet, but you can do a tiny little drop, and her procerus is not really that significant. So I think this is really where the rubber meets the road here. This is where we got to get that line taken care of. But she has 3 kids she has to worry about, so that's
Each of those lines are for one of the 3 kids.
That's sure helpful. Probably got more than one for each kid. Lines you didn't even know about. Okay. Well, I say 3, it's really 4 kids.
4, the biggest one.
Yeah, the older one is probably the biggest kid of them all. So, and then I'm going to turn your head this way a little bit, and so we'll do lateral canthal lines. At the order, it doesn't matter. I think in some ways, everybody's a little different. It depends on in terms of sensitivity, what they feel like hurts the most or doesn't. But I will tell you that the best way to avoid bruising, which is most common in the lateral canthal line area, is to put the skin on very good spread and then really look very carefully. And with good lighting, you can avoid a little pinch here. You can avoid any vessels, and you want to develop a little wheal here. 12 units per side is excellent. 10 units is fine, which we used for many years. And I can do a little drop down here too if she's got a line. Just don't want to be deep here. That line would have been the stingiest one, that last little drop. If you go deep inferiorly here, you can pick up the origin of the zygomaticus major or minor muscle and get a little bit of smile drop. It's I've never had it, but it's theoretically possible. I've seen patients with it, so I've never had it in mine, but I've seen patients come in with a smile asymmetry from that affecting it. So, and then this side we'll see even a little better. And give me a good squint here, and so you can see all that area. And I will, again, I'm going to put her skin on stretch, look for vessels, avoid, develop a little wheal. And I'm almost pushing the skin onto the needle here, and on this side I did 4 in the end, but you can do it in 3 or 4 little drops. The idea of doing the single drop and massage the wheel technique, I'm just not a big fan of it because, I mean, these things really don't hurt very much. So that if you use really small needles, and I'm using the, this is the BD needle, that is the 0.5 ml, and then if you use other products, I would use different sizes of the BD needle for the different products that are out there, but it's going to be pretty long before we run out of different syringe sizes. When I say needle, I meant the syringe sizes. This is 0.5. There's a 0.3 they make and a 1 ml, but as we start getting into 4 or 5 available products coming up here, it's going to be a little harder. We're going to run out of syringe sizes. So labeling them is another way to do it, which is a smart way to do it. And these were already pulled for me. And so they will, in my office, they will come in the morning and, you know, literally reconstitute whatever, 2 or 3 bottles. And then once it's reconstituted, if you refrigerate it, it's really fine for, the data's on file. Allergan is not on label. You know, it said originally that you had to use it within 4 hours, which is really silly, but proteins are not stable, you know, when they're in heat. So if you reconstitute them in water and keep them refrigerated, if you don't use any drop, they're fine. But for the most part, we use so much that they're not sitting around for very long. So this is the one part for her that's the tricky part, because she does not need heavier brows. And but so the way to do this is to make a nice even distribution. And I was saying before, raise your brows for me. So her muscle ends right about here. You can see where it starts to go down. That's because the muscle is attached to the skin, and when the lines are going down, there's no muscle. So really that's suspending or bringing the skin up is a suspension. Goes from side to side. There is, in her case, probably not much of a diathesis or split in the muscle here. People who have a split will often have lines that are more like the McDonald arches, you know, with kind of on the 2 sides going up. So she probably just has pretty much very small diathesis in the middle, but they're still innervated by the frontal branch of the facial nerve from each side, so it's independent branches. And one side can be higher, maybe this side's a little bit higher than this side, but I mean, it's so subtle that in her I wouldn't make any adjustments for that. And I'm going to do some little drops here. You have your squeeze ball, so okay, so raise your brow way up and relax. And that M configuration that you saw, I think, is good in my drawings or in the diagrams that were shown. And I'm going to do little drops here in that M configuration. And again, if you can avoid vessels by looking very carefully, you'll have happier patients with no bruises. If you do see a little reflux, you know, holding direct pressure is the way to do that. And if you hold it for a minute, what would be a bruise will just be a little tiny dot and not anything of significance. So that was the one that had a little reflux. Otherwise, the rest were good. And I still have maybe a couple units left. Raise your brow once more. So maybe a drop up in the frontal hairline here, so on each side, so she doesn't have the giveaway lines that I mentioned. And I'll do one in the midline since I had none here. and that's the completed treatment for online or on label Botox, and a patient who's younger and but will benefit from doing this on an ongoing basis. You know, this is the best results really are for people who over time continue to be treated, because some of these resting lines will go away. The skin does remodel itself when you're not firing those muscles, so we will keep her smooth and young and beautiful for, you know, till she gets to, you have to change her plan when she gets 50, I don't know.
You're not a magician.
Yeah, of course, you wanna go to your computer now since we've completed it?
Yeah. Yeah, so we're good. We're gonna go back over to the lecture, and
Yes.
so that was fun. That's first, I haven't seen that patient in some time, you know, like pre-pandemic, that sort of stuff. So that was nice to, and we're seeing lots of patients back now that, you know, I think everybody is now that the vaccine is out, and we're, you know, hopefully, you know, everybody, all the doctors are, I'm sure, are aware of how important it is that we're still physicians and central to the communications, and there's some vaccine hesitancy out there in the world, so hopefully everybody's giving good messaging to their patients that it's safe and effective, and that way we'll avoid the sort of India crisis that is tragic. But what we're seeing is everybody's coming out of the shadows now, and they're wanting desperately to get their hair colored and their Botox and their fillers. So I'm sure that everyone's feeling and even if you're really just starting, it's a great time to start, because you have a chance to, you know, get messaging for people who haven't been treated for some time, and so we'll start from there. Are you gonna do a question? Do you have a survey thing that you're doing?
I do, yeah, it would be the next slide, please. And next, test your knowledge. According to market research, what do patients value most in a neurotoxin treatment? And this kind of goes into the business side of Botox as well, but it's quite interesting. So does anyone want to take a guess of what patients value most? Maybe type it in. What do you think, Dr. Maas?
I think they look more relaxed.
Right, natural look.
Yes.
Yep. So our market research, surprisingly, it's safe and predictable results. So yes, looking natural, not looking fake or frozen, and then safety. Actually, more so than duration and cost is what they find most valuable. So next slide. And these are the studies we talked about, Dr. Maas. These are all yours. So, you know, there's a couple that we had chatted about, but please, you know, it's all you.
Yeah, well, I think that the point that Summer made is really important, and that is that patients value a natural look, and the safety, the early issues, which, you know, going back to the early 90s with Botox, because it was the only product around for over a decade, what was about safety, you know, and then people were hearing it's a poison, it's a toxin. I think if they were going to rename it, probably they'd take the tox out, although it works fine for us now. But it's really, as I explained to our patients, all of our medicines are toxins in the wrong dose. So it doesn't, you know, medicines are all have some toxic level. Acetaminophen is the best example, which is highly toxic to the liver in wrong doses, but very good analgesic when it's used correctly. that was surpassed probably 10 years ago in terms of patient concern with the fear of the frozen look, which almost exclusively comes from overtreating the frontalis muscle, as we talked about before. And if you can't move your forehead at all and your brows are very flat and your eyelids are hooded because you're so frozen that you can't raise your brows, otherwise the frozen look does not come from not being able to frown. That's not, a lot of people can't frown. That's just not a feature that happens. And squinting is so, and lateral canthal lines is so highly variable in terms of who has it and who doesn't, and even at what age they have it, that those areas are not the issues. It's solely the frontalis that is the over-treatment of the frontalis that is causing this frozen look and phenomenon. And part of that is because, in the early 2000s, late 90s, but early 2000s primarily, there were, the thought leaders that were out promoting using, 96 units, I think was a paper published in the upper face only, which meant that you were using 40 or 50 units in the forehead, which does make it flat, as they described at the time, flat, smooth, and shiny. But on the other hand, that is not natural looking and is really, not where we want to go. So the data that we've shown and the dosing that we've shown are proven and studied and are effective in getting good outcomes. And these are from composites. The data that you're looking at in front of you are composites of where the responder, this is where the subject is grading themselves and the investigator is grading, and they both have to get, on a 4-point scale, they have to get 2 points of improvement, which is really hard to do, honestly. I think if you were doing it on a 5-point scales, if we were going back, we would use 5-point scales with all of these. 5-point scales are much more effective. But that's the constraint we have. The 2-point improvement from baseline but it's still, the numbers are huge. And this, if you remember our little line, this is the glabellar lines, and this is the frontalis lines. I don't know if you're not seeing mine, but on the top, the Botox cosmetic, where it says 20 units, that's the frontalis or forehead lines, forehead FH forehead lines, and then the 20 units in the glabellar lines and the little icons you see. And they were in 2 different study groups. And then the second one, which came later, was doing all 3 together. And you can see the satisfaction rates and the difference, obviously, between a placebo. It's even interesting that they got one person in the second study that was a responder. That meant both the investigator and the subjects got a 2-point improvement, and some of them got a placebo, which I find shocking, actually, that there was even one. But the data is phenomenal. If you really looked at these, because my suspicion when you're talking about again, 2 grade improvement, people have a tendency not to grade themselves from moderate to none, and so these are the biases in 4-point scales. But the point is that you get really good results, and you get even better probably results in general when you do them together. That's here that you see that. The next slide. When I say do them together, I mean all 3. This is the same data, it's just shown differently. But looking at it, you can see that it was just what I talked to the patient about, that the onset is quite, you can begin to see onset within, a day or 2 in general, but by a week it's profound, and it's reached its peak of effectiveness here at day 14, where you see the small dots near the bottom. That's the placebo, the gray line, and but everyone else on this curve. And then you do see a steady diminution of effect. And typically when we do these studies, we define responder rates as when half of the subjects are still at that 2-point move on a 4-point scale. So if you were right where the 50% line is here, and I don't think you can see my pointer, but if you traced a line straight over from 50% on the left, I'm looking at study 1 now, and you went straight over from 50%, and where that line crosses is somewhere between 90 and 100 days. And that's when half of people are returning to baseline. But it also shows you that there are people that are outliers that can last for 4 or even 5 months. And that's true in real practice. And we also have done some studies which we've done them with Allergan, with other companies' products, but it is consistently true that higher doses result in longer durations. And that can be done safely. And we will probably, in the not too distant future, see some sort of delivery systems and bottles that are shaped differently, or maybe even preloaded syringes and things like that, that will get us super concentrated so you don't have to put a lot of diluent in and longer duration. That's talking about the future. But in this study too, you see the 3 areas were treated, the forehead lines, lateral canthal lines, and glabellar lines. And again, satisfaction rates are, when you measure these things, but these are again looking at 4-point scales, which are a little bit different than just grading whether you like how you look or not. Although both of them have to be included in all registry studies, they have to include now by just by rule with the FDA, they have to have a patient satisfaction scores. But again, these numbers are even, frankly, they're even better than what we saw on the other, on study 1. When you treat them both, it's like even more. Next slide. So it's same data, just presented differently. And so is this here, and it gets a little tricky because of the shaded areas, but just to make it clear, these are the difference was that this study was with repeated treatments, and I think the take-home message is that people the responses are not different based on how many times they're treated. In fact, they seem to get even a little bit better over time. I don't think that's statistically different than this first treatment area, but as they begin to understand what benefits they're getting, the grades seem to even rise a little bit. But I don't know, and so the higher these little bumps are, this is sort of the duration of one treatment, but you can see it's a little bit higher than what we did in the initial treatment, and the same with both studies. This is the other study where we did 3 areas, and that may not, the difference between the height of this line and this may not be statistically different, but it shows you that the more people do it, the more they appreciate the treatment. I mean, it's a good thing when you have not only consistency in treatment outcomes in terms of line effacement, but that people are grading it as being better, which I think they mean. In practice, it probably means they just like it better, because those are subtle differences. And then the next slide. So when we look at again, these are the studies, and this one is, this is where I was telling you about satisfaction scores are obviously in many ways much more helpful than, you have to have objective data, and the subjective data though is really, really high. 90% of people are mostly satisfied or very satisfied in both studies, and so those things are, the placebo patients are just anomalies to me. I don't even understand how they could get there, but they're super. Anything where you're in aesthetics, if you're anywhere in the 80s, you're doing fantastic. And there's some websites that do have patients sort of grade their overall satisfaction with outcomes, like Real Self is one, realself.com. I'm not promoting them, I don't have any financial relationships with them, but it is a good site where if you want to just get a snapshot of how people feel about certain treatments. And I'll tell you that in general, the web is full, if you go to these, are full of complainers more than they are people who are very happy. Don't typically have a tendency to go on and write about how happy they are, so you have to probe them. But even with that sort of negative bias with the internet, there's still very, very positive outcomes. Next slide, please. And this is, oh, go ahead. Question?
Oh, I was just gonna say, I actually have a question. And actually, if you wanna go to the next slide after this, 'cause I think we're done with this portion after this slide, and then we can go to questions, so sorry.
You want me to finish, or?
Yeah, go ahead and finish, yeah.
Okay, yeah, so again, this was the one where the facial line, this is called the face Q study, where people look at how, how much they like it at day 60, and the percent of patients that are, very satisfied or in the high 80s, 90% range. And it's just it's the outliers that are, I would say outliers, the people that are really hard to make happy, where you see the percentages, where you see some of those numbers. Because in general, with good what I would also say is that I didn't spend a lot of time speaking with an established patient about expectations. But I told her when the onset was and how long it lasted, but we really want to also talk about what they would expect to feel, and really the improvements they would expect to get in terms of people, what people might say. They look more rested, they look, people don't know how to explain why someone looks better, friends and people that encounter them, but that's a very common finding, that people look like they're more rested, or they look like their skin looks brighter, things like that. So those are common things that you'll hear, patients will hear. And the next slide, and then I think we're done with this section. And so I just the things we can say for sure, the predictability of outcome is all about having consistent units in the bottle. And I just, knowing a little bit of the science of this, it's very hard with this tiny of amount of protein in a bottle to be consistent with the unit dosing. The company that has seemingly the best track record, is in my experience, I would say this is true, is Botox. There's just not much variation. They're given a lot of leeway by the FDA, so there is bottle-to-bottle variation with all of these products, and Allergan seems to have the least amount of bottle-to-bottle in my experience, and I think that's a big thing. And almost the great majority of patients, once they start using this, are going to be recurring patients, people who come back to, and of course if they stay with you and trust you, then they're, at least for surgeons, they're going to ask you about eyelid surgery and facelift and other, or even nose jobs or whatever in the areas of expertise that I have, or whatever you have. That's where you can really offer some benefits. And I typically will, if they're getting a facelift or something, they haven't had Botox, they're certainly probably going to get a complimentary treatment at the end, because every little bit of those little nuances help quite a bit. So, and so I'll leave it. I think the next slide helps us to wrap that section up, if you can.
Great. So we're gonna finish and take some questions and discussion. And before we do that, I want to just take a moment to talk about something that I actually have the honor of being Dr. Maas's business development manager, and we work together a lot on the continued opportunity that Botox has in his practice. And your BDMs, I know you work with them as well, but just wanted to let you know about an upcoming campaign called the Look of 3. And that really brings together everything we went over of how we help bring patients in 3 times a year for that continued look, and then also optimal areas, 3 areas, optimal dosing. And we have some resources, Dr. Maas knows them well, an action plan worksheet, which I see on his desk right behind him, that we worked on. And that, please ask your BDM if they haven't already worked with you. That really goes through what the retention is in your practice and how we can help you with bringing those patients in. Allie is a great support that Dr. Maas also knows well, where it brings patients in, also has them go to dual treatment. It's your own retention and conversion program for your practice. Any words there, Dr. Maas?
Yeah, well, so there are a few things. I mean, the doctors, that are, like most doctors, I turn these things over to my staff, and I think my patients probably know more about Allie, and my staff certainly do, than I do. But I will say that you should take a few minutes to study it, because the little I do know, for example, is that with the new program, Allergan is actually giving you points, even if or your patients points, even if they're doing treatments that are not Allergan products, which is pretty remarkable, because they're just trying to build the whole pie rather than work on their own little slice of the pie, and I would give them a lot of kudos for that. Building, and it's also a benefit because most of these programs that are patient loyalty programs put the company in between us and the patient, and this is my personal feeling, and this has nothing to do with Allergan's. I'm just telling their program is great because it takes them out of the middle. By giving points for any treatment, we're developing loyalty for our patients, and they've taken themselves out of being in between our patients and us as it relates to loyalty and points and awards and things like that, which is a big deal. It's a big deal to me. I've always had that sort of mixed feeling about the loyalty programs, and we want our patients to be loyal to our practice, so if we can thank Summer and their team for doing that for us.
Great. Well, I'm going to open it up to some questions. Feel free to unmute and just chat, talk about anything that's on your mind. I do have one question here. The question is, occasionally I can't seem to avoid an angry look with tenting on the eyelids, especially in my Asian patients. Any advice about this?
An angry look. I would say that it's hard without seeing the patient, and especially in Asian patients, that's interesting. This is my guess because I'm not looking at the pictures, usually the angry look comes from the brows, being down medially and up laterally, because if you do a stick figure just like if you sit down on a piece of paper and draw stick figures and you do a diagonal with the brow, that represents somebody angry, and it may be that you're treating a little bit high in the medial frontalis, trying to get the corrugator and getting their brow to come down slightly, and that by itself, we don't want medial brow ptosis. We want generally the brow to be relaxed, and that's why I was saying be careful about over treating or treating too high when we're treating the corrugator muscle here. We want to stay at the brow, and otherwise you get the brow down in the middle, and that can give you an angry look. And look, there were papers written about this, so I would never fault anyone who didn't read one of these papers where they're doing more in the middle and less on the outside, and that's supposedly arching the brow, which in some people it does. In fact, most people it does, depending on how much you use. But keep in mind that gives you a downward slanted brow, medial brow ptosis, which gives you, if you do the stick figure, an angry look. That would be my best guess. That probably it's medial brow ptosis causing that, and the best example or metaphor or figurative description I can give of that is to sit down and draw little stick figures of the face and see what it looks like when your medial brow is down. So stay low on the corrugator and make sure you don't overdose in the middle part of the brow so that it drops. Make sure the distribution is nice and even across the frontalis so that it generally relaxes the lines and doesn't create the appearance of anger by dropping the medial brow.
Great, thank you. Any other questions or anyone want to chat before we end? We a little bit more time. Yep. Okay. Well, I think we're gonna let everyone go. 5 minutes, give them an extra 5 minutes of their Saturday. And I want to say thank you so much, Dr. Maas, for hosting this, and for everything you do for our industry. It's much appreciated. And I hope you and everyone else has a wonderful Saturday.
Thank you guys. Look forward to seeing you. Anybody that wants to get me offline can reach me through Summer. Dr. Maas at drmaas.com is my private email, so you can send a question or whatever you want to me, and I'll try to get back to you if you have offline questions you want to ask.
Great. Thank you.
All right, thanks guys.